Good day, my dear undergraduate students. The class for the day is spotters in pathology, namely tuberculosis kidney. This can be asked as a spotter. It can be leading to a series of questions in Viva voce, or can be kept as a gross specimen for description. I understand it is a little off track, but since it has been included in the practical so far, I am taking this class. A gross specimen. Always, when you describe a gross specimen, these things are mandatory. Dash into dash into dash. That means the length, the breadth, and the depth of the thickness. These three things are essential for any solid organ. If it is going to be a tubular organ like the intestine or a blood vessel, we will be measuring mostly the length. Secondly, I find it is rainiform in outline because nobody can say it is a kidney because it is almost devastated or destroyed like Ukraine. It is rainiform and there can be structures like the ureter or the pelvis that can save us. The cortex is thinned out. So this is the cortex. Usually I'll be finding a solid pyramid over here. Maybe in this region it is here, but elsewhere it is very difficult to make out. So the pelvic calyceal system, on the contrary, I cannot make out the branching primary and the secondary calyces at all. But most important will be on opening, the diagnosis is very evident. Look at this patchy areas. All the red arrows are all this. I find multiple patchy, yellowish, white areas of necrosis. They are semi-solid, cheesy, or pasty. Sometimes they can join together, coalesce together, and they form larger areas of necrosis. In fact, sometimes the entire kidney can be replaced by a cheesy material or a purulent material, which we call as pyonephrosis, classical of tuberculosis. The external surface, which is not shown here, it will be yellowish gray with adherent capsule. Tuberculosis is a chronic process. It will be there for a long time. Therefore, there will be inflammation, there will be fibrosis. Fibrosis will cause adhesion of the capsule. There also will be thickening. I cannot see the underlying parenchyma. It has to be peeled off. So please do remember these things. Courtesy Wikimedia. This is another specimen, a similar lesion. So in this, I'm lucky enough to see the dilated pelvic calyces, but the point is they are all blunted and distended. This is the solid parenchyma that I'm seeing, but more important is there are some yellowish brown areas of necrosis. This is purely fat. Don't mistake it. This yellowish white or grayish white areas will be the areas of necrosis. Look at this, another area of necrosis. An area of necrosis. Yellowish gray or grayish yellow, whatever you people like to see. Two things. The renal parenchyma is atrophic or thinned out. Cortex is thinned out. Distortion of the pelvic calyceal system. Multiple patchy grayish yellow areas of necrosis. The external surface is grayish yellow with irregularity and scarring. Now look at this one. Usually the inner surface will be smooth, but since tuberculosis is a chronic inflammatory process, it becomes roughened because of inflammation and fibrosis. Capsule is adherent, of course. I would like you people to kindly compare these two. This is a specimen of chronic pyelonephritis, a non-specific pyelonephritis due to any bacterial or other modes of infection. In this also, there is scarring of the kidney. Look at these lines, coarse lines, areas of dipping, etc. It is a coarse contracted kidney, or initially it is distended. This is fibrosis. And on the cut surface, I am able to see some violetish gray areas. It is schematic. Areas of scarring, and the calyx here is blunted. If you go to Robbins, you can see this particular picture. And compare these with our friend the tuberculosis of the kidney. So I'm not able to see this kind of an area in this. The yellowish gray, cheesy areas. So obviously you will be able to identify this. This is a superb schematic diagram over here. I'm able to see the pyramids and then there is a cortex over here. But more important will be the yellowish gray areas of necrosis. Caseous necrosis, cheese-like. This is the hallmark of any tuberculous lesion. It can be lung, it can be intestine, it can be meninges. What we are supposed to see is a granuloma. Granuloma means you find it is a small lesion, hardly about 1 millimeter in diameter. But then it is an aggregate of these cells. Look at these things are the nuclei. They are all slightly bent, bean-shaped nucleus. They are quite pale. But still more paler is the cytoplasm. Look at the abundant cytoplasm that I'm seeing over here. And this will be the necklace pattern of distribution of the nuclei. Many of these so-called epithelioid cells have fused to form a large Langhans type of giant cell. This is the cytoplasm, peripheral, horseshoe-shaped or necklace-shaped nuclei. And still outside, I will be able to see the lymphocytes. Epithelioid cells, then there will be the Langhans type of giant cells, the lymphocytes. This is a schematic diagram which people can draw subject to some corrections. Area of necrosis, I am able to see some bacilli, and these are the epithelioid cells, and surrounding it will be the lymphocytes. Look at the blue color. This blue color you people will have to draw over here. And the body attempts to rim them off from the surrounding tissue by means of fibroblasts, spindle-shaped cells. So I would like you to draw, and the organism also we will draw it as a pink in color because it is acid fast. And this area will be pale pink necrosis, not green in color. So these corrections you people can make, and you have got a wonderful diagram for your notes or for your any question on tuberculosis. Mercy. Thank you for your patient listening.